have drugs that are oral, that are, we call them targeted agents. They hit, like a molecular pathway inside the cell a lot, and they kill the cells a lot differently than chemotherapy does. And we have a number of new drugs that work through the immune system and try to attack the lymphoma that way. So when we have patients who relapse, probably the most commonly used second-line treatment right now is a combination of a drug called lenalidomide, which is a pill that's used in a few different cancers. It works very well for certain cancers, and it works well in follicular lymphoma. And that's given with the immunotherapy drug called rituximab. And that was proven in a study to be very effective. About 80% of people will respond to the regimen, and that remission on average lasts in the 2 to 3 year range. So that's probably the most commonly used second-line regimen right now in the US for follicular lymphoma. And then there are a number of treatments that are now available in third line and beyond that are new within the past, say, 3-4 years. And these newer treatments that I'm about to describe are now being tested as second-line treatments and even as first-line treatments. So it's possible that some of these treatments I'm about to describe will become, in the future, our go-to regimens for first-line treatment or second-line treatment. And we hope they do move up, because that means they're even better than what we've been using. So probably the treatments that we're most excited about right now in follicular lymphoma are the drugs called bispecific monoclonal antibodies. There's 2 that are now FDA approved. One's called mosunetuzumab, and that was approved about 1.5 years ago. And the other one's called epcoritamab, and that was approved just a month ago. And basically, these drugs are infused or injected under the skin, infused intravenously or injected under the skin, and they're proteins that will literally stick to the lymphoma cells. And when it does that, it kind of coats the cancer cells. And then after these bispecific antibodies coat the tumor cells, they literally will trick the patient's T cells, their healthy T cells, to come in and attack the cancer. So it's a way of trying to trick the patient's own immune system to come in and start fighting the cancer. And these 2 drugs are very promising in the relapse setting. They work about 80% of the time to get some kind of response. About 60% of the time, patients will go into complete remission, which means we can't find any evidence for the lymphoma on scans. And they're both so new that I don't think we have a full understanding of how durable these remissions are going to be right now. It looks like about, if you do get a complete remission, that about half of those patients are holding that complete remission at 2 and 3 years. But we don't know about 4 years and 5 years yet, because the drugs are too new. And we expect that as these drugs move up and are tested in the second-line setting and in the first-line setting, they'll work even better, because the cancer cells tend to be easier to kill in earlier lines of therapy. Other agents that have moved into the relapsed follicular lymphoma space would include CAR T-cell therapy. This is a fairly sophisticated, complicated approach where you actually will run the patient's blood through a pheresis machine, and you will extract the patient's T cells, and those T cells get genetically modified in a lab and then expanded, and then are shipped back to the center and then reinfused back into the patient. So now, again, we're tricking the patient's T cells into fighting their B-cell lymphoma. And there are 3 CAR T products that are now FDA approved for use in follicular lymphoma, and they have very high response rates with seemingly good durability. We're now getting 3 and 4 year follow-up for these CAR T products, with about half of people still in remission. The CAR T products probably have a little more toxicity and a little more risk than the bispecific. So I think most of us are thinking we would try the bispecifics before CAR T, but there might be certain patients where a CAR T strategy is more appropriate to use before a bispecific. So we're very excited to have these tools in our toolbox. It's always good to have more options. And then I should just mention the small molecule inhibitors. So here's an example. Just this past year, there was approval for a small molecule called zanubrutinib. It targets an enzyme called BTK, or Bruton's tyrosine kinase. This is a pill, really well tolerated. It's given in combination with an immunotherapy drug called obinutuzumab. This zanubrutinib obinutuzumab combination got FDA approved just this year for recurrent follicular lymphoma. The results look very good for that. It's very well tolerated. There's another oral agent called tazemetostat, which was approved a couple of years ago. It targets a mutated protein in follicular lymphoma. This is, again, is a pill, super well tolerated, very few side effects. So, you know, there's just a few examples for you of all the different treatment options we have for follicular lymphoma that has recurred after initial treatment. Believe it or not, the decision-making can be difficult when you have so many choices and so many good choices. That's a good problem to have. And I find myself a lot of times spending a lot of time with the patient and their family as we talk through these different options, and we try to think what's best for them at this point in time, talking through the pros and the cons, how active it is, what side effects do we need to be concerned about. And, you know, it's a lot for patients to digest when you have so many choices. But like I mentioned, that's actually a good problem to have.
I think you're right. There's a lot of hope in those options. I do have two follow-up questions. One of them is when you talk about lenalidomide, or brand name Revlimid, CAR T, bispecific antibodies, this new small molecule, are these all, quality of life is so important for cancer patients. Are these all limited duration treatments for recurrent disease when there's a recurrence of the disease, or are they long-term treatments for the disease?
Yeah, really good question. And the answer is different for every agent. So I'll try to just kind of run through the list. For the CAR T products, the 3 different CAR T products, it's like a one-time treatment and then you're done. Because the cells that get infused will persist in the patient's body for months and months and months. So they're infused and then the cells will hang around a long time acting on the cancer. So for the CAR T, it's a one-time treatment. For the bispecifics, the mosunetuzumab product is a time-limited treatment that is done in less than a year. The epcoritamab is designed to be given indefinitely. So there are some pros and cons to those 2 agents. The 2 small molecules that I mentioned, the zanubrutinib is meant to be given indefinitely, and the tazemetostat is meant to be given indefinitely. And then the first one I mentioned was the lenalidomide. That is in follicular lymphoma. That it was developed to be given for 12 months in this setting. So the duration of therapy is unique for each of the different agents that I mentioned.